Hi, everybody, and good morning. I will take my lecture right now. Uh, my topic is physical activity, oxidative DNA damage, and the risk of colorectal cancer and type 2 diabetes. Convincing evidence has been accumulated over the past 3 decades, clearly demonstrating beneficial effects of physical activity and exercise in terms of general health outcomes and also in cancer prevention. In this keynote lecture, we will a little bit focus on the role of reactive oxygen metabolites, particularly DNA damage products in defined clinical settings, and its impact on prevention and patient management in risk group, particularly in type 2 diabetes. What are we talking about? First, we will see that the tumor risk is moderately elevated in type 2 diabetes. Second, there are beneficial effects of physical activity or exercise, and beneficial effects are expressed in terms of decreased risk, particularly in active individuals. Then I will you introduce a little bit in the concept of tumor risk biomarkers, particularly the reactive oxygen metabolites. And finally, I will present you our recently published study, the COLO-DIAB study, which includes a characterization of risk biomarkers in different clinical settings, such as type 2 diabetes and in patients with curatively treated colorectal cancer, which have a high risk of recurrence. And finally, we will look for the potential clinical implications of our data, which means improvement of prevention and patient management. Diabetes and colorectal cancer risk. Over the past 3 decades, overwhelming epidemiologic and clinical evidence shows that there is an overall risk of diabetes getting cancer. And there is almost a strong association of type 2 diabetes with a relative risk over 1.5, particularly with liver disease, with liver cancer, pancreatic cancer, and endometrial cancer. But there's also a risk, but moderate risk for other diseases, including the colorectal and the colon cancer. They have mostly a moderate risk in the range of 1.1 to 1.5. And this is overwhelming evidence. You can see have been published over the last 3 decades, hundreds of studies comprising at least more than 30 million people. On the other side, patients who have a colorectal cancer with a pre-existing diabetes, they also have a chance for a worse outcome. The overall mortality is increased in patients with colorectal cancer which have a pre-existing diabetes. And this is even more expressed in women with the mortality is increased about 30%. So this means pre-existing diabetes is a risk factor for a bad outcome in patients with colorectal cancer. On the other side, also there are a series of studies and reviews and meta-analysis also comprising at least 1 million people showing clearly that physical activity has a beneficial effect in terms of lower risk. And this risk decrease is in the range of 20 to 30%. And there is probably also, and this has been shown also in many studies, there is an inverse relation between the intensity of the physical activity assessed in metabolic equivalent task hours per week or abbreviated MET hours per week with the hazard ratios. And you can clearly see that the hazard ratio, the standard ratio is 1.0, and with increasing MET hours, there is a decreasing risk, and which reaches, when you are very high active, reaches the range between 20 and 30%. Now we come to the reoxygen metabolites as quantitative biomarkers in oxidative stress. Oxidative radicals, superoxide radicals, hydrogen peroxide and hydroxyl radicals are produced in the mitochondria during the respiratory change. And this is increased production, and this can be measured with in terms of total thiol levels, the TTPs, or the total hydrogen peroxide, the so-called diagram reactants, which means the derivatives of reactive oxygen. And there's the analytical methods are spectrophotometry, automated analyzer, and these methods are very good for large-scale studies. But when you look at the oxygen radicals and their interactions with DNA, you can see that the DNA will be attacked by the radicals, and mostly are the bases oxidized. And one of the major bases is guanosine, and one of the major DNA damage products is 8-oxo-2'-dioxyguanosine, or abbreviated 8-oxo-DG. In the following, I will also talk about 8-oxo-DG in the abbreviated form. And these damages products can be measured and are detectable in biological specimens, biopsy, urine, or blood. And they have more sophisticated analytical methods, particularly HPLC electrospray mass spectrometry. These methods, or when you measure DNA damage, this is not so very good for in mass screening because of the complicated analytical method. And this is a very good research tool, and also can be adapted in defined clinical setting with rather small numbers of patients. Now, the detection biological samples, you can see here an example, mass spectrometry of GNM of DNA from colonic biopsies, and you can see here the peak of the H-oxo-DG. Or you can this also measure in urine samples, as we did in our studies. The 8-oxo-DG is elevated in conditions with increased oxidative stress, higher BMI, older age, smoking, occupational hazards, and other factors. And is also elevated in diseases, and this is the topic of my lecture, in diseases with increased tumor risk, including CRC. These are chronic metabolic diseases like type 2 diabetes. Type 1 diabetes is questionable. The studies are rather contradictory here. Chronic inflammatory diseases, particularly inflammatory bowel disease, chronic rheumatoid arthritis, and other malignant diseases. Also curatively treated CRC, we have a high risk for relapse in near-advanced radiation and after chemotherapy. Now we will present the COLO-DIAP study, the aim and intention. This study has been published in February this year in Endocrine and Metabolic Science. The major intention was to compare risk biomarkers in different risk groups. We took, in my clinic, mostly we have type 2 diabetes and cancer patients. Diabetes, as we all have shown, has a moderately elevated risk, and the CRC patients have a high risk for recurrence even when they are treated curatively. The controls are, of course, of this average rich. We will show you that if there is a correlation between demographic parameters in these study patients, BMI, physical activity, smoker, body mass index, and other parameters, and correlate these risk parameters, disease-specific parameters in type 2 diabetes with P and postprandial blood glucose, HbA1c, and in CRC patients, tumor localization, histology, and the tumor stage, TNM classification. Now there is some of our details of our study, the exclusion criteria. The inclusion criteria were the age, as you can see here. Exclusion criteria, of course, any malignancy or present or in history, and common other exclusion criteria were other major concomitant diseases. In colorectal cancer, we have, of course, if it's an age-matched study, so the patient population has to be of the same age. And we also took in a exclusion criteria was the UICC stage over 3. This means these patients had to be curatively treated with no lymph node or distant metastasis. Of course, other chronic infections, rheumatologic diseases also were, and also language barrier and absence of consent are these the usual common criteria. It was a case control study, so the controls were retrieved from patients or their accompanying patients which attended our research centers, the NCT in Heidelberg, or affiliated hospitals. Other individuals were recruited from the city and state registration authorities. So this is a clinic. These patients are from our clinics, and these patients are recruited from different registries. What are the major difference with these groups? Type 2 diabetes, CRC, and control. Just to make a long story short, type 2 diabetes, as expected, have a higher BMI, and their activity is lower. So you can see the physical activity in these patients is the proportion of patients with low activity is almost something in 46% compared to only 32 or 15% in controls. So this means that patients with diabetes have a higher BMI and are physically less active. This can be more or less expected from other studies. Now, let's go to our major results. What we could find, of course, was there was a positive correlation, as can be expected, between the body mass index and the urinary excretion of log-oxo-DG. We measured this concentration in the urine. And if you differentiate this, you can see that the correlation is closer and higher in controls than in the patients, in the CRC patients, and in the type 2 patients. There is almost the correlation you can see is not significant. What we can see, the BMI is positively correlated in the urinary excretions in the whole study patients, and the increase of BMI is by about 10 corresponds to an increase of approximately 0.3 log-oxo-DG in urinary excretion only in controls. Now we come to the most important questions. Is there a correlation between the levels of physical activities measured in med hours per week and the urinary excretion in study patients? You can see there is almost no significant correlation. So there is no significant correlation of physical activity levels and the urinary 5,8-oxo-DG in type 2 diabetes and CRC, and a non-significant correlation in the controls. Then we looked at the relationship between the metabolic parameters in type 2 diabetes and levels on urinary oxy-DG, and you can see that there is no correlation between HbA1c and the pre- and postprandial glucose, as well as with the HbA1c. So there is no significant correlation of metabolic parameters with 8-oxo-DG. Next, we can see, if you look at the comparison of the urinary 8-oxo-DG excretion in study patients, you can see there is a big difference between the colorectal cancer, which has the highest, as probably can expected, they have the highest concentration of 8-oxo-DG in their urines, and the controls, of course, the lowest. And what is interesting, and this is a new finding which has never been demonstrated before, that diabetes is intermediate between the colorectal cancer and the controls. So we can see what does this mean in epidemiological terms. If you compare our results with data from epidemiological studies, you can see that if you see the controls have a hazard ratio by definition of 0.1. And from studies, epidemiologic studies, there is, as we also have shown in one of the first or two, in the first two slides, the diabetes has a hazard ratio of about 1.3 to 0.5 hazard ratio for risk of colorectal cancer. And the colorectal cancer they have a high rate for recurrence, which is at least 3 times higher. And if you compare this hazard ratio with our data, you can see that still the diabetes is in between the colorectal cancer and the control. So we can say that urinary excretion in diabetes is in between CRC and controls, and hazard show moderate risk for type 2 diabetes is already known. And also, and other oxidative stress parameter may thereby, and this is the next question, should be implemented into risk prediction models to improve accuracy. This means the discriminating power. And this has been done also from a group in our institution at the NCT in Heidelberg. And they could show if you include in the risk prediction models derivatives of reactive oxygen metabolites. These are the DROM metabolites because they are easier to measure in mass screening, as I also mentioned earlier. And you can see if, for example, for lung cancer, if you see that there were two studies, two cohorts studied, the ESTER study and the Tromsø study, which are included in this paper. And you can see that the AUC will be increased when this established predictors in these models were implemented with oxygen radical metabolites. It's an increase, small, but it's a significant increase. And this still also holds true, as you can see, for the colorectal cancer. If you add or implement these oxygen radical derivatives into existing prediction models, you also can see a significant increase in your accuracy from 68 to 71. 71. There is no, the thing is that this holds not true for all cancers. For example, in breast cancer or prostatic cancer, you could not find any improvement in the prediction models by adding oxygen radical metabolites. So we can probably say inclusion of reactive oxygen metabolites into risk prediction models significantly improves accuracy in lung and colorectal cancer, as in our cases, but not in breast and prostatic cancer in population-based studies. You can also show in other, I will just skip this, showing the same. Now we will come to the effects of exercise. Short-term exercise, we did a study just more than 10 years ago in which we measured the 8-oxy-G excretion in colorectal patients exercising with a medium intensity and compared them with high intensity. And what we could find that, as can be expected, if they are training for 3 weeks, you can see that the 8-oxy-G excretion decreases by about 30%, whereas high exercises increases it. So this probably means that there is a homeostasis relation. This means that in moderate exercise there is a beneficial effect of in the patients, whereas if they if there is they exercise on a high level, there will be a deteriorating effect. This so this leads to completing some or in meta-analysis, it could be shown, and this is the Joel Radak showing that exercise, probably the moderate exercise, has the most Belsen effect. If you look in this, the next is the exercise model. Stress has inflammation in aging and activation of antioxidant defenses is at transcriptional, translational, and enzymatic levels. In the next you can see that one major mechanism is that moderate exercises activates and antioxidant defenses, such as the sodium SOD, the CAT and the GPX, and a decrease in pro-oxidant factors. You can see in exercising patients there will be an increase of the antioxidant defenses, whereas pro-oxidant factors will be decreased. Regular exercise also improves DNA damage, as can be seen in this study. You can see controls and type 2 diabetes, and you can see if the controls exercise, the telomere length will increase. This means that your DNA gets better, and this effect could also be shown in type 2 diabetes, as you can see here. This was a very excellent study by Ivan Di Mauro from Rome. Then the higher the oxygen balance, the lower the cancer risk. Here you can see in this summary that oxidative stress factors are listed on the left side, and the defense factors are here on the right side. If you enhance the oxygen defenses, your cancer risk is lower. This is the basic message of my lecture. This can also be seen that if the higher the oxygen balance score, the lower the risk of colorectal cancer. This we can probably skip and use in the discussion. Now we come to the conclusion and the further research proposal for clinical scientists. Increased oxidative stress in many chronic diseases, including diabetes. The BMI correlates with urinary excretion in study patients. Beneficial effects of weight loss are associated with decreased oxidative stress biomarkers, and hormesis relationship between exercise intensity and oxidative damage parameter favoring probably moderate intensity. Improvement on patient management, we can see that the implementation of biomarkers into risk prediction models probably will further benefit the screening for the intervention and screening progress of the patients. And finally, the limitations of our study is the integration of biomarkers improves the risk prediction models, and this should be implemented into national and international screening programs for risk groups to guide further steps, for example, earlier colonoscopy in type 2 patients. And finally, 8-oxo-DG is a good risk parameter, biomarker in research settings and in defined clinical settings, but less well suitable in large-scale studies, as we have shown, for example, at the population level. Thank you very much for your attention. Okay.
Thank you for your lecture, Dr. Hobart.
Thank you very much.
If you have any questions for him, feel free to ask.
Okay.
Dr. Feng and Dr. Gupta, if you have any questions for him.
Okay, I mean, sir, actually, I don't belong to this field of work exactly. Professor Algier, I have one query, that is, what are the contemporary competitive techniques to what you propose? Is there any?
So you mean the technique to measure the?
I mean, some contemporary competitive techniques with what you propose.
The technique to determine to measure the 8-oxo-DG.
Yeah.
Okay. the most is, I will show you, this is mass spectrometry. Moment, I've just can show you this picture.
Yeah.
Here you can see. The thing is, there you have to see two different ways, approaches to measure oxygen radical, the reactive oxygen metabolites in mass screenings, where you have a high amount of patients, thousands of patients. Mass spectrometry is not the best method because it's technically difficult and it's very cumbersome. So the mass spectrometry is a research tool and will remain a research tool and will be a research tool, and in defined clinical settings with a rather limited number of patients. Whereas in mass screenings, you should measure the derivatives of oxygen metabolites, like the hydrogen peroxide, which can be measured spectrophotometrically, and this can be measured in an auto-analyzer.
Okay, sir. Okay.
Okay.
Okay, thank you, Professor. Yeah.
So, okay, thank you.